Well, thank you. Can you all hear me? Well, I'm alrighty. Good evening. Good evening. Thank you, Elder Jessica Harvey, for that wonderful introduction. I thank God for being present here on today. To be able to be before you with my partner in the co-faith, big sister and mentor, Reverend Dr. Sherry Jackson, and amongst the other leaders and visitors and friends that are here this evening. So I am very grateful to be able to come forward to you, and I kind of want tonight's conversation to be just that, a conversation. So please, as Elder just said, put your comments in the chat. We will try to I will try to answer as I go, but if I feel like time is getting kind of condensed, we can also save to the end, because I know there are things that I will say that may spark some upfront questions. So I do not mind. At this time, I'm going to share my screen and we're going to get started. Let's see. All right. Can everyone see my screen so far? All good, perfect. Okay, so this presentation that we entitled was "Death in the Dying Process: Palliative Care and Hospice: The When, Why, and How." And I think the reason why this was key to being a part of this conversation is because I think it is very taboo. Most times we shy away from conversations about death. What does that look like? Even as people ourselves, telling our family members what our final wishes are can be a very tough talk. And so, what I want to do is try to find a way to myself and Dr. Jackson, I'm sure, are trying to help people along the way to make this understand that this is a process that it's hard on the mental, but it doesn't have to be devastating. We want to help you to understand the process, the resource, what's out there for you, and how this can be navigated with grace. So on to the next slide. So the goals of today. As I stated, we want to provide you with education and insight on these processes. And more than anything, the biggest thing when I was kind of thinking about how can we engage people, what is usually the these taboo with entering or requesting palliative care and or hospice services. And a lot of it has to do with debunking the myths that are surrounding with how people die, what happens in the dying process, what when you enter palliative care, when you have to enter into hospice services if they're appropriate. I want to show you the benefits. And also I want the goal tonight. And when I was preparing this, it wasn't just about being education. I really want people to feel a sense of freedom, healing, and maybe even clarity. But for those who may have entered into had experiences with these two entities, and it may not have been the best. I'm praying that it's freedom to you all. And what is our role as and as clergy, as people who are to help people in the divinity space throughout this process. So I put palliative care, and the reason why I named it living truth of what it is and when it's necessary. And I put the emphasis on living truth because guess what? Palliative care is a resource that is provided to you when you are living. Okay, it is helping you to be in a space where you're able to have a quality of life while living. And I don't know if there was anybody that didn't know that, but I would be interested to see if we didn't. So next slide. So I kind of broke this down, and we really could spend a lot of time on just this slide right here, but I'm going to do my very, very best to make sure I try to summarize and make it understandable for you guys. So the formal definition of palliative care is the type of specialized medical care that is used in combination with primary care treatment plans, with the focus being on symptom relief from other serious or life-threatening illnesses. So with that being said, this goes alongside if you're getting some kind of formal treatment for some type of chronic illness and or um, um, issue that can be life-threatening or end of life, right? But the goal of palliative care kind of shifts. The function is to be utilized when medical care is with the goal of the control of disease or cure of the disease, of curative intent. So as you can see, palliative care goes in combination with other treatment forms to help when you are trying to overall improve your quality of life. What I mean when I say that is, let's take, for example, with the space that we see palliative care operating in all the time is when we're coming to in cancer, right? And if I have a patient that comes to me and they're seeing me in clinic and they come and I have them on treatments, which I know are going to affect the way they eat, is going to affect the way they eliminate and with their urine and their bowels, is going to affect pain. And so when I will do my best as a provider to get that under control, as I'm trying to cure their disease or as I'm trying to control their disease, but I may have hit a wall and I'm like, you know what? I've tried X amount of nausea medications. I've tried X amount of pain medications. I've tried, X amount of natural remedies. If I hit a wall and I feel like, you know what, I want somebody who's going to be able to focus solely on their symptom management. All I want to do is treat their disease. All I want to do is treat the cancer. I send them to palliative care. I hope that makes sense. So it shifts the thought of what palliative care is. So it doesn't take me away of focusing on treating your cancer. Guess what? I'm gonna send you to the palliative care MD, PA, or MP to focus solely on helping me get you back under control with your nausea, get your pain under control, guess what? Your mental well-being under control. They will help institute different modalities at different points along the way and helping me, and we combine. So what does that provide? It goes into the next thing. So it identifies what the goal of the care is. So upfront, am I curing this disease or am I controlling this disease as a chronic illness? It helps me, these partners with me, with symptom management, right? But not only am I treating the patient, the palliative care aspect treats the family as well. Because you have to know, the one thing that I learned as a nurse, and especially in the cancer world, is I have to be able to take care of everybody that's involved, not just the patient. And so even to that point, the psychosocial, because I tell people all the time, I can treat whatever illness you give me, but if your social situation is in a bad way, it makes it very hard for me to try to treat everything else. And so we have to try to treat mind, body, and spirit, right? And so I pull palliative care on board with me to help me go and figure this thing out. So a lot of questions I get is, who is this appropriate for? Guess what? Anyone, any age that is under some type of treatment, for any type of acute or chronic illness that may be diagnosed in the short-term interim or length of their life. So you can have palliative care. It could be just for a short period of time, but it can also be as long as we need it to be on board. Some disease types that are available in this space, because there are some specific disease types that you commonly see with palliative care. Of course, cancer is one that we know. Cardiovascular disease, so any type of heart failure, any type of peripheral vascular disease, peripheral artery disease, things of that nature. If you have dementia, Alzheimer's, or some type of other permanent memory loss, respiratory illnesses such as COPD, emphysema, things of that nature. And there are other qualifying diagnoses that come under being able to partner in conjunction with palliative care. So I hope this kind of changed the mindset of some people of what palliative care really does. It is actually there to partner with people like me who treat cancer and other illnesses to help focus on solely their symptom management as it relates to mind, body, and spirit. I hope that kind of summed it up. I know I was moving kind of fast. So of course, put your questions in the chat or you can chime in with questions. So I think this is the part that I was really excited about, y'all. Let me go ahead and clear up some myths that I have seen. I have either heard myself or that I did a little research and looked up. So I hope by the description up front that I've already kind of given you some of the answers, been a myth buster, if you will, about palliative care. So first one that we always hear, palliative care is only for people that are dying. Well, I think I explained that one up front, is that no, this is actually for those who are under treatment and management of their disease from a curative perspective or control perspective. The next one, palliative care is another name for hospice. It is not. It is starkly different. Now, where I want to kind of insert something here is you will hear the terms palliative care, hospice joint and coupled together. Because believe it or not, palliative care helps to bridge in between wherever we are, right? May I be, like I said, control of disease, cure of disease, and it helps bridge into when we get to the point where we're no longer curing disease, but we need to focus on comfort. And I'm going to get to that. Again, palliative care is only for people with terminal illnesses. It is not. It is for those. And if just in case, I want to make sure I break everything down, because I don't know my range of people on. So when we're talking about terminal illness, we mean illness that is going to lead to end of life. So palliative care is not just for terminal illness. It's actually for, like I said, living individuals and to help control throughout. The next, when I receive palliative care, I will no longer be able to receive treatment for my disease. Well, again, I spoke to that. It's actually in combination with treating your disease. They focus on symptoms. I focus on disease management and treatment. Okay. Another one, I can no longer see any of my healthcare providers. Well, again, myth busted. It's in combination. It literally, palliative care is a part of a multidiscipline. When we say that, a multidiscipline picture, that means I have the primary provider that's treating, right? Treating the illness. Palliative care comes on board and treats symptoms, may include your other specialties, heart if you need a heart doctor, lung doctor, kidney doctor, foot doctor, even if you will, whatever. And then we all become a part of the story. So the palliative care is actually a part of what we call multidisciplinary care, if you've ever heard that term. The next one, palliative care makes people die sooner. No, it actually makes you live longer, because I'm trying to improve your quality of life by controlling your disease and symptom management so you can go out and live your life as I would intend it for be, as God intended it for it to be, right? And the last one, palliative care is only for those who are in pain. Well, obviously, as we talked about, it's about all symptom management. So it's not just for pain. It's for nausea. It's for insomnia, so those who can't sleep. It's for those who experience chronic pain. It's those who may have anxiety, those who may have depression, those who may have decreased appetite, those who may, listen, and the list goes on. So palliative care is so multifaceted, y'all, that it helps all of these entities function. Okay? So palliative care, just before I move on, are there any questions about palliative care before we transition into the talk about hospice care? Anything in the chat, Jess? Because I can't see it.
I haven't had any questions, but I do have just a statement, might not be a question, so to speak. Why do we not hear that term more often? Because this is honestly the first time I've ever heard it. And I know you know my situation personally, but I've had to deal with hospice and things that or even transitioning, and I've never heard of this term before. Is this something that is often spoken?
So that's a good question, Jess. Yes. So I think the reason why it's not often spoken is what I said earlier. You will see it lumped in together where they'll say palliative care hospice. And so what happens is we drop it off and you say hospice, which is why people have always kind of considered it one and the same. And so it's become more of, and I'll also say like in the past several years in healthcare, honestly, insurance companies didn't cover it. So it was almost like an out-of-pocket expense, or it had to be like deemed put as a responsibility to the primary treating provider. So it kind of evolved over time that we realized, okay, we need a palliative care specialty and it needs to be its own thing. Because as I said, it can take me away from treating your illness if I'm only focusing on your symptom management, and I can't even, like, I'm trying to get you to your next level of treatment, or I'm trying to continue your treatment, but I'm every visit I'm always talking about, well, I can't control your nausea. And it also can be a benefit, because if they're getting your nausea under control, then I know I can still I can continue treatment, right? I think even at times we want to make sure that when you're on different treatment modalities, that I am keeping you on that as long as I can, as long as it works, and not having to stop a treatment because it's giving you severe nausea or diarrhea or pain. It makes sense? So I think what happened in the past is they got lumped in, and it really wasn't just like this big push for it, that we understood that it was a need. And then I would say it's evolved probably in the last 5 to 10 years, where it's like, okay, no, this needs to be its own thing. So a lot of times it just kind of got lumped under the hospice specialty. And we used to say, oh, it's just a bridge to hospice. Well, no, we realized, guess what? It could be outside and apart. So that kind of was like a medical thing that kind of did it. But it probably wasn't as well spoken about in the past. You are correct. So, so moving on, hospice care, and I put the music, dun dun dun. And the reason why I did that is because it says it's time to change the perspective. Listen, y'all, hospice care is a good resource when it is appropriately implemented and used, okay? And I know a part of it, I've heard some people say, well, I did hospice for my family member and it wasn't a good experience. And I really do apologize for that. And I think a part of that is twofold. We may have agencies that are just not doing the proper due diligence and taking care of people in their end of life phase, right? But I also think a part of it is because we're not well educated about what hospice is, what it does. So we know that there's a standard of when these people come to help take care of my loved one. This is what they should be doing. A, B, C, D, E, F, G, right? And you advocate for your family members when we think things are not going well. And to the point, I'll say this, even if you feel like that agency may not be the correct one, switch agencies, because that could be the case too. It could just be the agency. All right. So going on, hospice is different from palliative care because it's a specialized type of medical care that is provided when those who are terminally ill and no longer in pursuit of curative treatment. So we're talking about people who they've been on a lot of treatment or under a lot of treatment for their particular illness. And either one of two things happen: that we've run out of options to treat that, or I have treated you to the point where if I continue to treat you, it could be more harm than good. And so as healthcare providers, we took an oath to do no harm, literally. And the Hippocratic Oath is across healthcare professionals that we take when we come on to treat people. And we took an oath to do no harm. And so that means that when we get to a point in treatment that, yeah, I could keep going, but this is going to be worse for you, I have to come in as a professional who knows better and say, listen, I can no longer treat you because at this point, I'm not going to do benefit for you. And so that's kind of a time where I think it's important to sit with a healthcare provider, and you can say, is hospice appropriate? Or we will tell you. We will tell you. So, as I said, the function and the goal is to be utilized in a space when medical care has the goal of comfort measures only, not cure. We're not trying to cure at this point. Okay. So what does it provide? It initiates goals of care. So when I say that is, we have a conversation about, okay, what do you desire to be the outcome of your illness? And then as a medical professional, I tell you what we can and cannot do from a medical standpoint. Huh? And I'm going to insert something that I always say with me as a medical professional and as a licensed minister, as God's mouthpiece, if you will, right? I always say where medicine ends, God's continue. I mean, Elder Jessica tell you that. I've said that several times, and that is my belief. And so I have become very good at talking in this space when this is good. So symptom management is here as well, and it helps individuals and families navigate a difficult decision, and psychosocial support. So again, the total person. All right. Now, where palliative care and hospice care differs is who's appropriate. So it can come in at any age, for any age, but the specifics is they have to have a qualifying diagnosis with a life expectancy of 6 months or less. Now, I'm going to give some wiggle room to this because hospice has evolved so much that there are patients who have been on hospice for longer than 6 months and they still get to receive hospice care. Okay. But that has to be at the discretion of a healthcare provider who comes to look at the patient, evaluate them, and see if they can stay on service. Okay. I do that all the time as well. And there are 9 specific disease types and areas that hospice can qualify for. And I thought I pulled it out. I do have it available really quickly. And I'll go over those really quickly. So the specific types are cancer, end-stage Alzheimer's and dementia, end-stage cardiac disease, end-stage liver disease, end-stage pulmonary disease, end-stage renal disease, end-stage stroke, and cerebrovascular disease, end-stage ALS, which is Lou Gehrig's disease, and end-stage HIV and AIDS. So those are the 9 categories that you would have to have at end stage to qualify for hospice. So hospice qualification is a little bit more stringent than palliative care. That's what kind of makes it a little different, okay? And if you're not certain, you can always talk to a medical professional who can tell you, listen, this person will qualify, this person will not. Now, again, this area is where I'm praying that, my prayer has been that maybe this is freedom, and I'm, to get into like the death and dying process, all together, right? So some myths. Hospice care is when you're giving up, hospice care is when you are giving up and losing hope. It is not. I want you to know that when you are instituting into hospice, I actually see it as a thing that's you're entering into it from a brave place, a place of wisdom. It does not mean you have given up. It means like, listen, I want this phase of my life to be done in dignity, where it's not traumatic to me or my family or myself for that fact. And that I am bringing people on that's going to help me through this process. Another myth, hospice is only for cancer patients. Not true. As you can see, I just named 9 qualifying diagnostic topics, because there are other diseases that fall under those 9. Another one, if I elect hospice care, there is no turning back. Guess what? Yes, there is. You can get on service hospice today and get off tomorrow. In addition, if as a medical professional, I evaluate you and you're on hospice, as I said, that 6-month mark, we're looking and going, okay, you haven't gone to transition. I can look and say, listen, this patient hasn't made a decline. So guess what? Come off service. I have to put you off hospice services. And guess what? I have done it on more than one occasion. And I've had people that have elected not to be on it anymore and go back into active medical treatment. This one, I like educating about. I can no longer see any of my healthcare providers. Guess what? Myth busted. When you're on hospice, I have you under one of those 9 diagnoses, right? And guess what? If you're not on, say I may have you on for your lung cancer, but I don't have you on there for your hypertension, your diabetes. Guess what? You can still see your primary care provider, but I will have you on service for just your cancer. So you won't be able to see your cancer providers anymore. But guess what? You can see your primary care provider. You can still see your cardiologist. Now, that rule just came about maybe in the last couple of years. So you can still be in seeing your healthcare providers. This one, hospice care makes the person die sooner. It does not. It does not. It does not. It does not. It actually helps you to transition as your body transitions. And I'm kind of speaking through this because I want to talk about it. And I just realized I didn't put the slide in for it, but I'm going to speak to what the body does in the dying process. So that'll help free some people up too. And I hope it helps you to know when it's appropriate to institute hospice care. Hospice is only for those whose death is days away. Well, I bust that myth because guess what? I got people who live for greater than 6 months and they are still on hospice. And then as you can see, hospice care is only for the elderly. That's not true. I have on service, the company that I work with, we have the youngest person I think on service currently is in their 30s. I've never seen us take children. There are certain agencies that will take children, but it could be through the lifespan. Okay. So I'm gonna pause here and do the general takeaways. So palliative and hospice care are covered benefits under your medical insurance. Amen. So guess what? This is of no cost to you when you are when it is covered under your medical insurance. The next one, there is a multidisciplinary team, as I talked about it. This is going to include a lot of people in this entity. You're going to have your providers who are going to be caring for you. May that be a medical doctor, an NPRPA. You're going to have a nurse. You're going to have an aide. You're going to have social work. You're going to have a mental or a mental health care provider. The social workers also function as licensed providers in counseling. And you will have clergy, as we have a reverend doctor who is certified as a hospice chaplain. Okay. And then there's palliative care and hospice can require a healthcare provider and or recommendation. And you yourself can always inquire and initiate the discussion. So palliative care actually requires an order. As of late, hospice only requires a conversation. It does not require an order. You can tell a physician that you listen, I think I need to institute hospice, but then all you do is contact the hospice agency. They come in and they have a talk, they inform you and do things of that nature. So I know this was really quick. This is a lot of stuff that gets condensed in, like, I could talk about just one for an hour, but I tried to hit the high points as much as I could to make sure that, look, I'm trying to help bust some myths about it, help people feel more comfortable when this is appropriate, or even when it's appropriate to talk to a medical provider about one of these entities. Now I'm gonna quickly go into, I'm gonna stop there and see if there are any questions, comments, concerns thus far.
People are just sharing their comments in the chat. No real questions, but no just sharing their experiences.
Yeah. And I'm sorry, I'm like sharing my screen and trying to like fit everything in. So I apologize. But I will, see in the when we get to the question and comment section, like some of the stuff that y'all are offering up. So the real thing about the death and dying process, especially as it relates to when we're transitioning in from a palliative care aspect into hospice. Because sometimes you will, like I said, palliative care is still used as a bridge into hospice, but it doesn't have to be. When someone is in the death phase, or if they're at the terminal point of illness, there are different signs and key things that the body will do that will tell you when a person is at the point of moving into the dying process part of it. So a lot of the struggle that we have when people get into hospice care is, oh, I don't want my family member to have morphine. Morphine kills people. And or I don't want them to sleep a lot. I don't want y'all are starving them. I can't tell you how many times I hear that. I'm going to help a couple people out. When you get to the end of life or in a period of when your body is starting to transition into being end of life, your body starts to break down, and the first thing that usually shuts down is your GI system. So most people will not want to eat. And so I think a lot of family members, this is a big thing. My family member didn't eat. They're not eating. I got to get them to eat. I got to get them to eat. Because in our natural mind, yeah, eating gives you energy. It gives you the nutrients and things you need. But what you will see, usually, the first thing is appetite will decrease or simply disappear. Another thing that will happen, give me 1 second. Okay. It will happen, will be like they'll start to sleep more. Okay. You'll see people sleep more than the 8 hours of required time per day, right? You will also see people start to talk less. They will engage less. They will not desire to really engage in conversation. Their energy levels will start to decrease, right? And this is the body's way of preparing itself. The body is very smart, guys. It's a way of preparing itself to transition. And so what I don't want us to I want to help somebody here, because this is the one thing that like God was really just showing me while I was working through this is maybe if somebody felt like they made a bad decision about, oh, my family member didn't eat, guess what? Their body was already preparing itself to transition, to not really want the nutrients. It was preparing itself for a formal state of rest. And so you will get different things to happen. Like I said, GI to decrease, things of that nature. And so I want you guys to be reassured when you start to see a family member who is starting to exhibit different things, different side effects and signs of end of life. I think it's when it's appropriate time to put into hospice care. And then call in the people that's going to help walk you through that. And what does that look like when somebody goes from not eating, not sleeping a ton, not speaking, to maybe periods where they don't breathe. That's called apnea. There may be periods where they have trouble breathing. Guess what? That's when morphine is appropriate. That's when Ativan is appropriate. Those things help to make the respiratory system ease and calm out. Not that it killed them. It's helping the body as the body prepares to go to its formal state of rest, final rest, if you will. And one last thing I want to talk about is hearing. So to be honest with you, hearing is the last thing to go when somebody is dying. So I always tell all my families, look, be mindful of what you say. These are people who can still hear you and they still have active thoughts. And sometimes you'll see it physically manifested when you said something that a patient, they want to respond to, but their body physically cannot respond. And then they start to get agitated. They may breathe faster. You may see them cry, even though you don't hear them crying. You can see them crying. That's a way that lets you know, look, they can hear you. So I always tell my families, cease negative conversation at the end of life. Because guess what? Hearing is the last thing to go. If you want to say something to them, say some prayers, sing a song, give encouraging words. Let them know that I am here with you, but listen. And I'm not only speaking this as a medical professional, I'm speaking this as someone who had to walk this thing when I buried my mom. And so I went into the room. I sung with my mom. I prayed with my mom. And guess what? I told my mom, guess what? Mom, I'm gonna be okay here. I may not like this, but I'm gonna be okay here. You are free to go. Y'all have no idea how hearing is the last. Would it be in the last thing, but it's also being mindful of what you say. And so all of these things, like I said, this is very condensed, but all of these things really like help you understand when this part of life, when we're transitioning out of an active part of life and into the death and dying phase, and then into final transition. But guess what? I'm saying all of this just as a quick reminder, but if you ever need somebody to help you through this process, that's where hospice is available to you and can help you through the process. And so, listen, we got more time. Dr. Jackson needs to speak, so we can also do more questions and answers at the end. So I'm going to punt the ball to the Reverend Dr. Sherry Jackson. I know it was a lot, but I hope it was informative to you guys.
Thank
to
you,
be of
Minister.
assistance to you, Rev. To be of assistance to you, Rev. If anyone would like to ask questions, because we would like to give Reverend Jackson more time to speak, if anybody has any questions, please put them in the chat box, and I will try my best to get them to her so that she can get her presentation. But we are going to do our best to allow her to get at least 10, maybe 12 minutes in, and we'll do the questions at the very end. And if there needs anyone that needs to hang over, we can, because we want to be respectful of time, but we would like for her to be able to speak on her expertise as well. So please, if you can allow her to get about 10, 12, 14-ish minutes, we greatly appreciate it.
So thank you, everybody, for allowing me to have this time to come in to punt and to be in alignment, to collaborate with Minister Witt, because hospice care is indeed an holistic approach. It is a holistic approach. It is a team approach. All disciplines are a part. So when you come into hospice, even palliative care, there is a medical provider, there is a dietitian, right? There is a social worker, there is a chaplain, because we are looking at mind, body, and spirit. So we can just move ahead in our slide. So it is one of the reasons why we don't receive all of the hospice benefits that we can, because we are afraid. And by the time we get into hospice as Black folks, so to speak, we don't get all the benefits because we are so afraid, and we are almost close to dying before we get in it. If you get in it at the top of your diagnosis, you will enjoy more of the benefits, right? When people are scared to get on hospice, but when they graduate or have to get off, they are mad because of all of the great services that they have received. So that's not my point, but I just wanted to say that. To pick up the idea of when a person is dying, right? From a spiritual care provider, right? People are not concerned about their religious practices. It is their spiritual needs. There is a difference between a spiritual need and a religious need. A spiritual need is an internal. How is the being? How is the being? Your religious practices are your external. At the end of life, nobody is asking how many times you went to church. Nobody is even asking how many times you read your Bible. What people, as they are dying, people are concerned with their internal. Who am I? Right? Will I be remembered after I leave? Right? And your religious practices are your external needs. What I do, going to church, reading your Bible, take communion, all of those are religious practices. Spiritual needs, we all have the same spiritual needs. And I just wanted to go through, as a chaplain, a board certified chaplain, specialized, I call myself a doctor of the soul. And I'm not talking about the part of you that go to heaven. I'm talking about your core being. People have spiritual concerns. They have spiritual needs, right? and they have spiritual issues. And so what my job is, as Minister Witt is taking care of the body, I am taking care of the soul. So we're going to so there are about 14 spiritual needs. If we can advance, there are about 14 spiritual needs, and the number one spiritual need is to have a need for meaning, value, and purpose and hope. Meaning, purpose, and hope. So what does this mean? People want to know that they matter. They want to know that they belong, and they want to know they have some type of purpose, that they've had purpose in life. This is a spiritual need, whether you are at the dying process or you are living. One of the number one questions people ask, why am I here? Why am I here? What is the meaning behind all of this that I'm going through? What is the meaning of this suffering? Why do I have this illness? Why is this happening to me? That is a spiritual need, right? And so as a chaplain, and many people decline the chaplain because they think that we are death whisperers. They think that we are coming. I have had families to tell me, I don't want that energy in this house. I don't want no chaplain in the house because I don't want nobody coming to talk about death. That is not my role necessarily, to come in to talk about death. But a spiritual need that people have is they want to make sense of this suffering. And many times people often say things like, I know there's a reason why God has me doing it, for a reason, right? Because they want to make sense of. If people can make sense of why something is happening, it seems that we can get through it. So there is a spiritual need for meaning, for purpose, and hope. And let me tell you, as a spiritual care provider, I never take away a person's hope. I never take away, if they are double amputees and they tell me they want to walk again, I'm going to stand with them until, and I might have doubt in my mind and be like, listen, I don't know how you're going to walk because you ain't got no legs, whatever, but I ain't going to take it away from them. I'm not going to take away a hope of a family member. Now, there is a thin line between denial and having hope, right? And so when I see that a person is in a perpetual state of denial, sometimes I have to just come in and tell them, listen, this person is indeed dying. Right? This person is indeed dying. Another spiritual need that people have is a need to transcend the circumstances. They want these circumstances to just leave, right? They want these circumstances to just leave, especially when they have a diagnosis of an untreatable illness, even if they fall and break a hip. Right? Dementia, the loss of recognition. And so they try to look beyond. They know what's going on, but they want to look beyond that. They don't want to deal with it at all. So they have a spiritual need to transcend their circumstances. There is a spiritual need for support in dealing with loss. And we've talked about this all for the last couple of weeks. People have a need to deal with the loss that they are experiencing. This is a big one. When a person is ill, has a terminal illness, has a chronic illness, the worst thing that we could do is try to take away their independence. If independence is no more than being able to put on their socks, right? Let them put on their socks, because people have a need for continuity. They have a need for things to be the same, because we live by habits, right? We live by habits. And so they have a need for continuity. So as much as we could keep things the same, or at least with modifications, it's okay. To make that helps people to get through this. Another thing is they need a validation and support for religious behaviors. Now, let me just say this. As a chaplain, I am not your pastor, right? I am not the pastor. I need to put this in the atmosphere that a lot of times pastors and clergy are not trained in good pastoral care, or they don't deal with death and dying well, right? I don't need a person. Here's an example. Here's an example. A boy, a 10-year-old boy was he was dead. He was dead. His grandmother was in denial that he was dead. When a person dies, they call everybody in, the nurse. Now, this family never wanted the chaplain to come because in her head, God was going to heal. And if I came, then I was going to represent death. The boy is dead, right? They called the pastor in. Now, listen. I'm Holy Ghost filled, fire baptized, and all of those things. The boy, can I tell you the boy is dead? The pastor comes in, puts everybody out of the room because he didn't need non-believers in the room because he was going to raise the boy from the dead. Let me tell you something. I'm in a tough situation. I am not the pastor. Right? So I got to make a decision. What do I do? They put us out of the room because he needed to pray. Now, at this time, this ain't got, for me, it don't have nothing to do with God. It don't have nothing to do with anything. His ego became the center. This grandmother is, she's holding on, and she told us we could leave because if she needed us, she'll call us back. No, we can't leave nobody. Right? That is not hope. As Minister Whitney called, that is harm. That is harm. And he worked that thing for an hour or so. And we finally had to call the police. Right? And so I'm all for supporting religious behaviors. I'm all for you praying. I'm all for you doing all these things. The boy is dead. And so finally we asked, could we at least clean the body? Can we take the tubes out? And she finally said yes. When she came to herself, she went the opposite direction. She became angry and she just started throwing all of the medical, the equipment and all of the supplies out of the house, right? People who are dying, they want to engage in the religious behavior. So that's when the pastors and people from the church should be coming to visit, should be coming to bring communion if they are able to do that. The spiritual care provider, that is not my role, although I can. I am called to deal with wherever you are, regardless of your religious affiliation, right? I don't care if you're atheist. I don't care if you are is a Muslim, whatever you are. That is not my role, right? I'm not to get you into heaven. That's your pastor, is to help you get into heaven, right? Now, if you come to United Fellowship, then that's a different role that I have, right? So people have a need for personal dignity. People want to die with dignity, right? You can push to the next one.
Rev, before you continue, I just want to point out you good. It's 7:30. If there
Okay.
is anyone that has any questions, we're not going to stop the presentation because I think she's on a roll and I know she doesn't have much more. But I do want to be respectful of the time that we have set. If there's anybody that has any questions at this moment, you can feel free to ask them, but we are going to continue on. We will not be much longer, we promise. But I think we all can agree that on the line that all the information that's been shared is very, very important and vital. So I'm asking that we can just have a little more patience. But if you do have any questions, or if you do need to leave and you would like to ask your questions before you log off, please let me know and we can pause the recording and then restart it. Just let me know. If not, Reverend Jackson will continue with her wonderful presentation. And like I said, if you need to leave, we love you. Thank you for joining us. But we're going to get this good information.
Thank you. Another thing is for a need for unconditional love. So people, when they are dying, they often want to know that their loved ones, that they have done enough, that they want to make sure that they are loved. They want to no judgment. This is not a time to go back to the past and get up all the things that, right? Now, but I do need to say, we do help facilitate reconciliations from family members, from children who have been estranged from their parents, from siblings. We do facilitate reconciliations of estranged family members. Now, I need to say this. People have a need to express anger and doubt. Please do not try to tell a person how to feel. Do not try to tell a person how to feel. It's okay to express anger, and it's okay to express doubt. And hear what I'm saying. God can take your anger, because a lot of times we are really angry with God. Why are you doing this? I've lived a good life. Why are you doing this? I'm angry. And so because we don't allow people to express this anger, they don't really, the anger that they have for God, what happens is they put it on people that surround them. People have a need to feel that God is on their side. They have a need to love and to serve others. They have a need to be thankful. Now, this is a big one. Many people have a need to forgive and to be forgiven. For people who they've wronged, who wronged them, a lot of times they want to get it right before they leave. They want to get it right. Sometimes the person who they need to forgive may not be ready to receive the forgiveness or to offer forgiveness. You cannot make a person accept your forgiveness, or you can't make people forgive you, right? And so we help people to work for that, and a need to prepare for death and dying. I need to just say this. Many times family members tell us, don't tell the patient that they are on hospice or that they are dying. I think that is selfish. The person who is dying needs to be able to process this thing. Don't cheat a person because you are not able to handle it. Don't cheat a person from going through their process because you are not able to handle it. There's only so much talking around a person we can give. So if that's what you are asking of me, never to mention the word dying, never to mention, I'm probably going to decline coming. Because it is not about you. It is about what that person needs to be able to go through their process. You may advance it. Now, I'm going to end on this. We need to avoid saying to a dying person these things. Don't offer advice. Don't offer advice if I were you. Do not tell a person what they should do. Don't offer advice. Don't make comparison. I don't care if you had the same kind of cancer that your second cousin had. It is not the same. Do not compare. Don't tell stories and this is good pastoral care too. If you are visiting the sick in the hospital, don't go in there telling the story about somebody else you know who had the same thing and they died. Don't do that, right? Don't make these grand spiritual statements. So what do I mean? Yes, God can do anything. Yes, but every person won't be healed on this side. That pastor who tried to raise that boy was out of order, right? And if you don't focus on a person's illness, a person try to act and talk about as many other things than the person's illness or their dying. Remember I talked about people have a need for continuity. Talk about things that you would talk about if they were not ill. Don't ask a person how they are. Well, how you doing? Don't do that. Don't be overly optimistic. It's a border. It's really a thin line for holding out hope and being in denial. Don't say everything happens for a reason. If I'm the one dying, I don't care what the reason is. Right? Don't say this. Don't say they are in a better place. I don't care if they in a better place. They ain't here with me. Right? We need to avoid saying these things. And most of the time we say it because we want to seem like really spiritual or things of that nature. But much of the things that we say cause more harm than good. Please don't say, I know how you feel. You don't know how I feel. You don't know how that person feels. And don't tell a person not to cry. And many times we do this because we can't handle it. And again, we are doing that because of our own selfish reason. And don't tell a person to be strong. If they want to fall out on the floor and do whatever they need to do, let them do it. I was working emergency room. A mother was, they were getting ready to take the tubes, her son off of life support. She was on the floor at the hospital. I mean, she was really having a time, right? What did I do? I didn't tell her to stop crying. I didn't tell her to be strong. I got down on the floor with her and let her do, and she eventually calmed down, but we want to make sure we are not saying these things in an effort, maybe for good intentions, but we really don't want to say them. Don't say your mom really wouldn't want you to be like this. Your husband really would want you to be strong, right? Don't say it could be worse. What is worse? Don't say you need to do A, B, and C. Please, let's not do these things. If you don't know what to say, please, just don't say anything. If you don't know what to say, the greatest present, the greatest ministry that you can have is to just be present. It's called a ministry of presence. And we don't know how to just be. We don't know how to just be quiet. We want to do something. We want to say something. That's why we want to feed our family members, because if we could just say that we did all that we could, right? So that's why if they just eat, they can be strong. No, but really, you might strangle them, and they might really die from strangulation because they couldn't swallow, right? And so I just wanted to offer these things to us just to be present. Don't say anything. And I do want to offer this, and I will close. Sometimes we need to allow people at the funerals to just fall out if they want to. We need to allow people to just cry. I'm talking about praise breaks. Hear what I'm saying? Praise breaks at funerals sometimes work against us because they become masks that prevent people from really screaming and crying when they need to. I'm all for a good praise break. But after the praise break is over, after we've cleaned out the kitchen, people go home and they sit in silence, and that's when people need us the most. People will have all kinds of family members coming beforehand, but what they really need is somebody to be with them for the days and the weeks afterward. That's why hospice follows a family for 13 months. That's all. May all be well with you. Thank you.
What an amazing presentation from both of our presenters tonight. Thank you so much, Minister Washington and Reverend Jackson, for all of your insight and knowledge and all of it. Thank you so much. We all are better because you guys shared with us tonight. Thank you to everyone who joined us tonight. I am not the person that's closing out. Pastor Boykins will, but I just wanted to, as your facilitator, say thank you for bearing with us. And once again, thank you so much, Reverend Jackson and Minister Washington. At this time, before Pastor Boykins comes, does anyone have any questions or comments or anything that they would like to say before we close out? I know some people are saying great job and things in the chat, but is there anyone that has any questions or anything that they need to say? And I will stop the recording at this time.